Hello, my name is Theresa Nguyen, and I am a gastroenterology T32 fellow at Baylor College of Medicine in Houston, Texas. The manuscript I will be discussing today is the external validation of a model determining risk of neoplastic progression of Barrett's esophagus in a cohort of United States veterans. This study took place at the Michael E. DeBakey VA in Houston, Texas. Thank you to my mentor and senior author of this manuscript, Dr. Hashim El-Sarrag, as well as the rest of my co-authors. And thank you to gastrointestinal endoscopy for this opportunity. Diving into the background, we know that Barrett's esophagus is the only known premalignant condition for esophageal adenocarcinoma. Effective prevention of esophageal adenocarcinoma has been thought to require identification of all with Barrett's and subsequent surveillance endoscopy of the Barrett's, which has been found to decrease the incidence, morbidity, and mortality of esophageal adenocarcinoma. Clinical practice guidelines currently recommend endoscopic surveillance every 3 to 5 years among all patients with non-dysplastic Barrett's to identify those with early neoplastic progression amenable to endoscopic treatment. However, the annual risk of progression from non-dysplastic Barrett's esophagus to esophageal adenocarcinoma is overall low at only 0.2% per year. Many would have unnecessary surveillance due to this low overall rate of progression. Given the rarity of progression, it remains unclear which patients with Barrett's will develop esophageal adenocarcinoma and benefit from endoscopic surveillance. The current model, with all undergoing surveillance at different intervals based solely on dysplasia status, does not perform well. It is not cost effective, with over 274,000 Barrett's related visits and procedures costing $18.1 billion in the US in 2015. There is a risk of unnecessary procedures in those at low risk of progression, as well as an impact on mental health, as endoscopy has been associated with significantly increased levels of anxiety, depression, and distress in Barrett's esophagus patients. Additionally, there is currently under surveillance among those who do progress, as 24% diagnosed with esophageal adenocarcinoma were found to have an endoscopy with non-dysplastic Barrett's within the last year. In an attempt to address this, Peraza and al. Developed a risk model for neoplastic progression in patients with Barrett's esophagus. The model contained male sex, smoking status, Barrett's esophagus length at diagnosis, and presence of low-grade dysplasia at diagnosis. On the left is a scoring system they developed based on the performance of these risk factors in their training cohort. And on the right is their scoring system that they then stratified into 3 risk categories: low risk with 0 to 10 points, intermediate risk with 11 to 20 points, and high risk with over 20 points. Their models both performed well in their validation set with the C statistic, which is equivalent to the AUROC of 0.76 for the points-based model and 0.70 for the 3 risk category-based model. The main gap that we are addressing with this study is that external validation of this model is needed in other Barrett's populations because differences in populations temporally and geographically can affect model performance. External validation in different Barrett's esophagus populations would establish generalizability of the model and provide further evidence for its use in clinical practice. This was a retrospective cohort study at the Michael E. DeBakey VA. All patients diagnosed with Barrett's esophagus from 1990 to 2019 were included in the study. Barrett's esophagus was systematically defined as salmon-colored mucosa of the esophagus on endoscopy and specialized intestinal epithelium on histology from targeted biopsies of these areas. Patients without intestinal metaplasia on biopsy from areas of suspected Barrett's esophagus were excluded. Those without a follow-up endoscopy after the index or Barrett's esophagus diagnosing endoscopy were excluded. And those who received endoscopic treatment such as RFA, APC, Goldberg cautery, and endoscopic mucosal resection on the endoscopy immediately following the index endoscopy were excluded. And those who had high-grade dysplasia or esophageal adenocarcinoma on index endoscopy were excluded. We define progressors as those with neoplastic progression being high-grade dysplasia or esophageal adenocarcinoma on any follow-up EGD, and non-progressors as those with no neoplastic progression on any follow-up EGD. The follow-up time was defined as time from index endoscopy to date of progression or last follow-up endoscopy for those who did not progress during the study period. Each patient was then assigned a score based on their risk factors from the points-based model developed by Prasa et al., which you can see in this table. The cohort was then stratified into 3 risk groups, low, intermediate, and high risk, based on each patient's number of points assigned as was done by Prasa et al. Using the graphic from the paper by Prasa et al., we can see the difference in annual progression per risk category in the Prasa cohort compared to our cohort. Their cohort had a 0.1% risk of progression in the low risk group, 0.7% in the intermediate, and 2.1% in the high risk group, while our cohort had a 0.3% risk of progression in the low risk group, 1% in the intermediate risk group, and 1.6% in the high risk group. Both cohorts each had an overall annual risk of progression of 0.95%. This graph shows the cumulative incidence of progression of the 3 risk groups in a competing risk progression, with green being the low risk, blue being the intermediate risk group, and red being the high risk group. The p-value by regression was not significant, however, at 0.326. We also restratified the cohort in our own proposed simplification of 2 risk groups, low risk being those with less than or equal to 15 points, and high risk being those with more than 15 points. We graphed the cumulative incidence of progression of the 2 risk groups in a competing risk regression, with blue being the low risk and red being the high risk group, and saw a drastic split in the 2 lines, with a p-value by competing risk regression of less than 0.001. We then examined permutations of the Prasa model to see if simplifying the model by removing one factor at a time would affect model performance. We found that excluding Barrett's length had the largest impact on decreasing the performance of the model on our cohort, while excluding low-grade dysplasia status at baseline endoscopy had no impact on the performance of the Prasa model on our cohort. This is useful because previous studies have shown large variability in the diagnostic accuracy of low-grade dysplasia by pathologists, with poor inter-observer agreement even despite the use of expert GI pathologists. Lastly, we found that the model did not lose predictive ability when categorizing Barrett's length as short, less than 3 centimeters, or long, 3 centimeters or more, rather than by each 1 centimeter, with an AUROC of 0.73. A previous study found that the absolute agreement within 1 centimeter for Barrett's length was only 68%, and so measuring Barrett's as short versus long for risk prediction can decrease the potential for misclassification and improve model accuracy. In conclusion, this was the first study to externally validate the Prasa model in a U.S. population. We were able to simplify the model to increase clinical utility without compromising predictive ability, by 1, changing Barrett's length to long versus short, 2, excluding low-grade dysplasia, and 3, reducing the number of risk groups to low and high risk. Future studies should focus on identifying more risk factors, such as genetic risk factors, for neoplastic progression. Thank you for listening to this video, and if you have any questions, please feel free to reach out to me at thn1@bcm.edu. Thank you.